All right, let's get you exam ready. In this high-yield explainer, we're going to tackle everything you need to know about anesthesia for minimally invasive surgery. We'll cover all the core concepts, from the nitty-gritty physiology to the critical decisions you'll have to make in the operating room. So here's our game plan. First, we'll look at the fundamental challenge of minimally invasive surgery, or MIS. Then, we're going to follow the patient's journey right from the beginning, the intense stress on the body, how we screen them beforehand, what we actually do in theater, how to spot trouble when it happens, and finally, what the outcomes really look like. Let's dive in. First up, we need to frame the single most important idea for this whole topic. Seriously, if you only remember one thing from our chat today, make it what's coming up next. And here it is. This is the phrase that just turns everything on its head, and it's a massive exam point. Minimal access surgery, maximum cardiopulmonary stress. You have to remember, minimally invasive does not mean minor anesthesia, not even close. The real challenge, the thing we're managing from start to finish, is the incredible physiological stress this procedure puts on the body. Okay, so how does all that stress actually happen? Let's get into the mechanics. We're going to break down exactly what's going on in the body's major systems during MIS. Because understanding this core pathophysiology, well, it's the foundation for absolutely everything else we're going to talk about. So it all kicks off with the pneumoperitoneum, and a classic exam question, right? Why do we use CO2? There are two absolutely critical reasons. First, it's non-combustible. That's a big deal when there's diathermy being used. And second, it's super soluble in blood, which massively reduces the risk of a catastrophic gas embolism if some gas accidentally gets into a vessel. This is another exam favorite. The effect of that intra-abdominal pressure, or IAP, on cardiac output isn't a simple one-way street. It's this really important biphasic response. So picture this. At low pressures, say under 10 millimeters of mercury, the squeeze on the abdominal veins actually helps, and it increases venous return and cardiac output. But then, as that pressure starts to climb, it begins to squash the vena cava, and that's when your preload drops and cardiac output starts to fall off a cliff. And this table, wow, it really lays out the widespread impact. It's basically a multi-system assault. So cardiovascularly, while your preload is dropping, the pressure is also squeezing the arteries, which jacks up your afterload and systemic vascular resistance. Meanwhile, the diaphragm gets shoved up into the chest, literally squashing the lungs. This wrecks your lung compliance, shrinks your functional residual capacity, and creates a perfect storm for VQ mismatch and atelectasis. And it doesn't stop there. Blood flow to the kidneys and the gut also takes a massive hit. Okay, so as if that wasn't enough, now we have to throw patient positioning into the mix. And this creates a classic anesthetic trade-off. You put the patient head down in Trendelenburg, and that's great for venous return and cardiac output. But it makes the respiratory problems way worse, and it can raise intracranial pressure. So you flip them, head up, in reverse Trendelenburg. That's great for the lungs, but now you risk the patient's venous return and blood pressure just plummeting. It's a constant balancing act. So, knowing all this, knowing how much stress we're putting the body under, our pre-op assessment becomes absolutely vital. Our number one job, really, is to spot the patients who just won't be able to handle this before we even get them into the operating room. And the thing to remember, the absolute key here, is that these contraindications aren't just a random list. Every single one is a direct result of the physiology we just talked about. A failing right ventricle, it can't possibly handle that massive spike in afterload. A patient in hypovolemic shock, they have zero preload to give. And conditions like raised ICP are absolute no-goes because both the pneumoperitoneum and the head-down position will make it so much worse. These are your absolute red flags. All right, so we've done our homework, we've got a suitable patient, and now we're in the theater. Let's open up the toolkit and see how we actively manage all these challenges while the surgery is underway. First things first, the airway. This is a huge decision. For a long time, a cuffed endotracheal tube was the undisputed gold standard, and it's still mandatory for robotic cases where you just can't get to the patient. It gives you the best protection and the most control. But for a lot of standard laparoscopic cases, the modern second-generation supraglottic airways like the ProSeal LMA are fantastic alternatives. They mean less trauma to the airway and a much smoother wake-up for the patient. Okay, let's talk fluids because this is a big one. The old way of thinking, just pouring in fluids, that's completely out the window. We now know that the low urine output we see during laparoscopy is a physiological stress response. It's not always a sign that the patient is dry. This concept is called permissive oliguria.
So the modern strategy is to aim for a near-zero fluid balance, treat any hypotension with vasopressors first, and only start to optimize the patient with fluid after the surgery is over and the abdomen is deflated.
And speaking of paradigm shifts, look at this. This is huge. For years, epidurals were the go-to for major abdominal surgery. But for MIS, they can cause more trouble than they're worth, with all the associated hypotension and delayed recovery. Today's enhanced recovery approach is all about using techniques like a single-shot spinal, maybe with a tiny bit of intrathecal opioid, all as part of a bigger, multimodal opioid-sparing plan. You get fantastic pain relief without all the significant downsides of an epidural. And you know, this stuff is always changing, which is what makes it so interesting. You have to keep an eye on landmark trials like Allegro. It was looking at whether giving an intravenous lidocaine infusion could be another powerful tool in our opioid-sparing toolkit, helping to reduce pain and get the gut working again even faster. This is really the cutting edge. Okay, so now we got to talk about what happens when things go wrong. Because despite all our best planning, they sometimes do. And our ability to spot and manage these complications in a split second is everything for patient safety. Now, this is a pretty startling statistic. Up to half of all the major complications happen right at the very beginning, during the initial access. As you can see, the small bowel is the most common victim. But an injury to the iliac artery or vein can cause a massive hidden bleed. And you, as the anesthetist, you're the one watching the monitors. You might be the very first person to know something is seriously wrong. And the problems can come from anywhere, really. They can be simple mechanical things, like the patient sliding down the table, or they can be much more subtle, like nerve injuries from pressure or stretch. In long cases with the patients in a steep head-down position, facial and airway swelling is a real worry, and so is compartment syndrome in the legs. And then you have the big one, a CO2 embolism. It's rare, but it can be fatal, presenting as a sudden crash in blood pressure and end-tidal CO2 that demands immediate action. And then there's robotic surgery, which brings its own unique set of headaches. We're not just dealing with physiology anymore. We're dealing with mechanical risks. The robot can fail, but the one thing you absolutely have to burn into your brain here is that once that robot is docked, you can't just run over and help. Your physical access to the patient is severely limited. That's why having a slick, well-practiced emergency undocking plan is completely, totally non-negotiable. All right, let's zoom out and put this all together. After we've navigated all these challenges, what does it all mean for the patient? What are the real outcomes? And what are the key points you need to take away for your practice and for your exams? So the bottom line is, well, it's a bit complicated. There's no doubt that for patients, MIS is linked to some great benefits: less pain, shorter hospital stays, fewer complications. But it's really hard to tell how much of that is the surgery itself versus the rise of enhanced recovery or ERAS protocols that go along with it. We also know robotic surgery costs a lot more, and when it comes to cancer surgery, the jury is still out on whether the long-term outcomes are as good as open procedures. If you want to dig deeper into any of this whole explainer has been built from some key review articles, especially the 2019 paper from Carey, Jones, and Fawcett in BJ at Education, and also the foundational work by Wong and Irwin. They're both excellent reads. And so that really leaves us with something to think about, right? As surgery gets even less invasive and more high-tech, the physiological stresses could become even more extreme, or just go on for longer. Our role as the guardians of patient physiology during these complex procedures is only going to become more and more critical. Thanks for joining me.